Good afternoon, and thank you for the opportunity to speak today. We're excited to share with how we operationalize bamlanivimab in the long-term care setting. We had the capacity to engage in phase 1 allocation of the monoclonal antibody through our health system and have successfully infused 95 long-term care residents across 11 facilities. As of today, we developed a turnkey program for our skilled nursing facilities that includes order sets and administration protocols to help identify residents who are symptomatic, recently diagnosed with COVID-19, and who meet the FDA emergency use criteria. The goal of our program was to really allow for ease of administration and clinical monitoring for our long-term care facilities. We established a coordinated effort between our pharmacy and each facility. And as stated before from almost every panelist, early identification is critical. We know that in the BLAZE-1 trial, patients received the infusion within a median of 4 days after symptom onset. And as part of being part of a larger health system, we were able to utilize an electronic COVID-19 dashboard, which would alert us if there were any new outbreaks in our system. And for some of our independent long-term care facilities, we relied on our consultants to keep in constant communication with those facilities to alert the pharmacy of a new outbreak. Once we were notified of a newly diagnosed patient, we initiated a conversation with the director of nursing and facility staff. And we recognize that there are huge staffing constraints and burdens at our facilities. So we really tried to target our program to help lift some of that burden by helping collect the data needed and by obtaining the physician orders. We would have an initial assessment of the patient to ensure eligibility of the FDA criteria, and would then initiate a second patient assessment prior to infusion to ensure the resident's condition has not changed or worsened. As we know with some of the exclusion criteria, if baseline oxygen needs increase, or if they now require oxygen with the new COVID diagnosis, that excludes them from receiving the infusion. We also have had other situations where the nurse was unable to obtain IV access. And so we kind of tailored our program after some of our first infusion sites. So we started asking that question early on. Are we going to be able to obtain IV access? We know that we have a shortened expiration dating. Once this medication is made, it needs to be administered within 24 hours. And so we want to make sure that if we're delivering this med, it's not going to go to waste because we don't have IV access. In addition to patient assessment, we heard this, Dr. Steinberg mentioned it, facility assessment is just as important. We needed to ensure that our facility staff can have and obtain IV access, is available for the 1 hour infusion and 1 hour post-infusion monitoring. We estimated it takes anywhere from 3 to 3.5 hours. We had one facility who created similar to an outpatient infusion center, brought their COVID positive residents who met criteria for the infusion into a larger room away from other residents and infused simultaneously. And that was a success because it didn't seem to put as much of a strain on their nursing time, where we had another facility who did not have a COVID unit designated. And so their COVID-19 positive residents were quarantined to their room. So they had to go into each room for that infusion and monitoring period. And it almost took the whole shift, which just put a strain on the nursing wing for that day. We really wanted to make sure that our facilities were prepared. And so we created these protocols, and it's hard to see right here, but this is the administration protocol, and it walks through the time of the IV placement and all the vital signs that are required, along with the recommended medications if there is an anaphylactic reaction. Part of our process when we dispensed the medication and the required supplies, we did send out a extra emergency kit that contained these medications so that they had them readily available when they were administering the medication. Right now in our system, we have about a 2% reaction rate. And similar to what Dr. Parada said, it is hard to distinguish between those reaction symptoms as they do mimic the COVID-19 symptoms. We are in the process of conducting a study on outcomes, and we're still in the data collection phase, but we're excited to hopefully have some real data that we can share soon. And now I'm going to turn it over to Mark to discuss the logistics of our program.
Thank you. Again, my name is Mark Gertis. I'm the Director of Pharmacy and oversight over the startup of the plan was really in my court. We were, like many people, in the midst of evaluating how we could potentially look at remdesivir as a potential in our long-term care when the EUA for bamlanivimab was established. And we found out on a Thursday that our health system was going to receive a state allocation. So our entire health system received 200 doses. On that same day, I found out that our pharmacy, since we do service outpatient, was going to receive 10 doses. And that was great news. I have a COVID SWAT team in my pharmacy consisting of pharmacists and nurses. And they came into my office all excited and saying, you know, let's get going. And okay. So we put together a plan where we talked about some of the documentation that was going to be necessary, the order forms, how we could lighten the load on the facilities, and what we were going to be looking for as far as patient outcomes, et cetera. And that was great. The next morning, that same team came into my office and said, we have a facility that on Tuesday had 1 patient, and today they have 15 patients. And I think we all know that scenario. And they said, this is our perfect test beta site. And I went, well, that's all great. But we talked yesterday and we said we'd roll this out on Monday because it's Friday and nobody does these things on Friday because that's a terrible day to do these things. And they, no, and over the next 5 minutes, they convinced me they had an answer for every question. Right. And I questioned hard and they pushed back, and tough crowd. So I said, okay, contact the facility, get the consultant involved. Let's see if this can be our beta test site. 1 facility confined, 15 patients. We'll see what happens. They came back into my office about a half hour later and they were furious. The facility had said no. And we're like, okay. Facility said no. They told me the story, all the conversations. What great empathy for the facility. They just didn't have the resources, right? They just didn't have the resources to run this. But I was also not happy because we've been seeing a 20 to 30% mortality when it goes through a facility. And that's not fair to say no based off of logistics. What did we need to do to hold their hand to get through this process and to use this? So I pulled the card from my sleeve. It happened to be an ACE, and I knew the owner, and I called the owner of the building. And I explained the situation. I explained the opportunity. Got through the call. 10 minutes later, I got a text saying the ball is rolling, and it did. The next day, we had done our assessment of 15 residents who were active. 9 of those received an infusion. We held their hand. It was our test pilot as well. We had 10 doses. We infused 9 of them the day after we received it. What a great story. What a great outcome for us. Overall, that facility has continued to call us as additional residents. I think we've done 18 residents in that building out of the 28 that have tested positive, and that's a positive for us. Some simple things that we learned following that, grouping patients, like Anna had mentioned, was a huge thing. Nursing time was huge, and timing. So we're going to talk about timing in a minute, but as you prepare to create a program, one of the things we say is people, communication, and materials. You have to have pharmacy people 24/7, 7 days a week. COVID's not taking a break. If you say you're going to do this, your pharmacy team better be ready to show up on a Saturday and help the facility. I'm blessed with a bunch of Midwest hardworking people who will do that for our friends and neighbors. So we're blessed with that. We have the pharmacy communication is in place. We also had some fortune in that our system has a senior care medical division. The senior care medical officer wrote an open letter to medical directors called Key Information for Medical Directors on Monoclonal Antibodies. And we were able to distribute that out as part of our informational packet to physicians and mid-levels that were not familiar with the monoclonals yet or hadn't had experience. So that was great. We were able to team up. Again, key staff, you have to have a director of nursing on board and you have to have a medical director on board. They have to fight through the process because it may not be their patient, but they may end up being the person who speaks with the provider and sells the product. There can't be gaps in your time, whether that be nursing, doctors, or pharmacy, or procurement of pharmacy purchasing. And as Anna said, this is early enough in the EUA process where we think data collection is one of the critical steps that needs to be followed up on. So my do the math slide. We were doing our second facility, ended up doing 26 patients at a facility. No, I'm sorry, the 26 patients, we ended up doing 19 of them. 7 didn't meet exclusion criteria. The day after we did the infusions, I received a call from the medical director. And he said, can you give me other ancillary things? Just like Dr. Steinberg said, what other things, the famotidines and the dexamethasones, what else should I try? Do you have an order set? And we did, we provided that as one of our forms. But we got into it and we finished that up. And he said, just one more question, talk me through this. He said, I have a room full of frail people. Did we do the right thing? You know, did we spent a lot of time and energy in the last 2 days putting this all together? And I said, let's do the math together. I said, right now we spent, and we went through it, and we spent 13 to 14 hours at that facility between nursing, physician, and pharmacy, 13 to 14 hours to administer to those 19 patients. They did it in 2 groups. One had 9, one had 10. We split it up. It worked out great. I said, if the Blaze trial is right, we prevented 6 hospitalizations. But let's be really, really conservative and say we only prevented 2 hospitalizations. Those 2 patients are going to go to an ICU bed. How's your ICU right now? And he said, well, it's full. I don't have an ICU bed. Okay, well, assume they could go to an ICU. That's 1 nurse, 24 hours a day for 14 days, 326 hours. We spent 13, yet alone throw in respiratory therapy, physician time in the hospitalization. And that's a conservative estimate. We need to, he just said, thank you. That I just needed to hear that. If we are going to proceed, we need to be able to have that do the math answer ready at our fingertips to prevent those hospitalizations, because even in South Dakota, where we don't have a lot of people, our hospitals are full. So lessons learned. Final slide. Gather a strong team 24/7, no gaps. Prepare, have your forms ready. Nothing more important than being able to hand off the form and know it's there. Know your facility capabilities. I service 80 facilities. We've only done it in 11. You have to know your facility. If they can't do it, if they're not up for it, go to the places that can. And then timing is vital. We've had 2 patients, one where the facility was supposed to administer it, said, oh, we're going to have to do that tomorrow morning. They needed oxygen overnight. We'd already prepared the drug. We had another facility that planned to do it in the morning, said, oh, we're going to push it back to this afternoon. And in that 4-hour gap that they went to push it back, they had 6 new COVID diagnoses and didn't get to the drug. Timing is critical. Get it in when you can. Don't let your staff put you off, and have the product prepared. I think I'm past my time. We'll open it up to any questions, and I thank you all.